Okay, thank you all for your attention today and for your attendance at from flare-ups to daily life bronchiectasis symptom management. My name is Marty Solomon. I'm an associate professor at the University of Alabama at Birmingham, and I'm the director of our Bronchiectasis and NTM Center. And I'm joined by members of our team today to talk about management of symptoms and exacerbations in bronchiectasis. We thank you for the opportunity to speak with you all today and look forward to the live question and answer after this presentation is concluded. Today, I'm joined by several of our team members, including myself, Dr. K. Vijay Kumar, who's an adult bronchiectasis physician, Dana Goodwin, who's one of our bronchiectasis nurse practitioners, Dr. Brian Garcia, our co-director of the Adult Bronchiectasis and NTM Center, and finally, Angela Thomas, our RN coordinator for the Bronchiectasis and NTM program. And I appreciate their willingness to speak to you all today as well. These are my disclosures. I want to thank Alyssa Dittner, the Assistant Director of Education and Community at the Bronchiectasis and NTM Association, and others at the association for support of our program and for giving us the opportunity to speak to you all today on World Bronchiectasis Day. The objectives for this session are to learn about the current understandings of symptoms and flare-ups or exacerbations, understand new developments for research and the horizon for therapeutic research in this area, and then to also interact with our larger team to answer questions about the care and the future of bronchiectasis and NTM, and understand how your team collaborates with you to help manage symptoms and exacerbations as an overall goal of this session. After discussing these objectives, I'm going to turn it over to Dr. K. Vijay Kumar to discuss mechanisms and management of bronchiectasis exacerbations. Thank you, Kay.
Okay, I'm going to walk you guys through what an exacerbation is and just touch on the basics of management. Dana's going to walk you through details of that after I'm done. So what exactly is an exacerbation? So we all know about the vicious cycle. The vicious cycle means that there is a cycle of chronic airway infection, chronic airway inflammation, and that may lead to impaired mucociliary clearance or the other way around. But together, the infection, inflammation, and the impaired mucociliary clearance causes lung destruction over a long period of time, which causes a normal airway, which looks like that, to be dilated, which is bronchiectasis, and gets filled up with mucus, which is what causes obstruction. So the interplay of inflammation, infection, and abnormalities is what ends up with an exacerbation when one or the other is out of balance, and they drive disease progression and further symptoms. So how do we define an exacerbation? This is something that we use for clinical trials, but it's been adopted for whenever we screen you, when you call us with symptoms, or to bring you to the hospital. So it's defined as 3 or more of the following for more than 48 hours, which includes increased cough, increased sputum volume or consistency, increase in sputum purulence, like you can see on the figure here on the right. This is what normal mucus looks like, and the worse it gets, it's more purulent. So mucopurulent to more purulent, and we know it's going from mild to severe. An increase in shortness of breath or decreased exercise tolerance, or both, presence of fatigue or malaise, or both, a presence of hemoptysis, and a clinical determination that a change is required in your current treatment and management. So the most important thing for us is that you have kept track of what's happening. This is an example of how easily you can keep track. This is actually downloadable from the internet. This enlists all of the symptoms that we look for in an exacerbation. So it's just going, if you took a week and then just marked it off and said, this is when I started feeling worse, and these are the symptoms I had, and these are symptoms that are getting worse, it's very helpful for you and for us. This helps us identify phenotypes. Why is this important to us? Because sputum production patterns are very variable. There are a lot of you that don't make sputum at the baseline, but make a ton of sputum only when you're exacerbating. And this helps us realize that prior exacerbations are the biggest risk factor for recurrent exacerbation. And we box you in something called a frequent exacerbator phenotype, because this helps us tailor treatment options specific to you, which may be different from what some of the others are, which may be something different that we use for other people without frequent exacerbations. Now, what are the predictors of a future exacerbation? We have studies to prove that the presence of Pseudomonas in your sputum cultures, a declining lung function as estimated by our FEV1, and a coexisting diagnosis of COPD are independent risk factors for a future exacerbation frequency. We've also seen that exacerbations may increase over time. This is probably one of the largest American database studies. This was commercial, the United States commercial claims and Medicare databases, which included more than 14,000 people that were followed out for 2 years. And we saw that majority of the patients experienced one or more exacerbations when we saw them at 1 and 2 year follow-up. You see these bar diagrams. Gray is 0 exacerbations, blue is 1, 2 is light yellow, and more than or equal to 3 is the darker yellow. And you see, as you go out to more than 2 years, the number of people that have more than 3 exacerbations without any interventions worsened. So how do we treat exacerbations? We have guidelines from several different international societies across the world. Most of us prefer to treat you with antibiotics for a duration of 14 days. How we start this is variable. We can start you off in an oral antibiotic, depending on how bad your symptoms are, or we can just bring you to the hospital right away and start you on IV antibiotics. But you probably will know this if you're somebody that's lived with bronchiectasis and exactly how we get started with treatment for exacerbations. So what happens if you get admitted to the hospital and come in inpatient? The first thing we want is to get a sputum culture. If we see you in clinic and decide to admit you, then we get a sputum culture in clinic. This is important for us to know what antibiotic to start you on. A lot of times we go off of what you've grown in the past in your sputum cultures. For those that don't make any sputum at all, but still check off the boxes for all of the other symptoms that merit an exacerbation diagnosis, we may offer you a bronchoscopy with a BAL so that we can get some samples from your lungs, grow that out in the lab, and tailor your antibiotics accordingly. We will always escalate your airway clearance frequencies in the hospital. You'll work very closely with the respiratory therapists for us to be able to do that. Sometimes you may require oxygen, so we'll titrate it, non-invasive ventilation if you have any kind of respiratory failure that's beginning to happen. If you're admitted with hemoptysis, it's a little different because we'll hold all of the positive pressure therapies because we don't want to dislodge any of those clots if they're there. And then once we've gotten hold of the bleeding, then we'll restart your airway clearance therapies. But you will start with getting antibiotics and everything else follows. So how do we prevent exacerbations? What can you do is to be regular and compliant with your airway clearance therapies. This is usually we start once a day or twice a day. And when you're exacerbating, we ask you to increase. Pulmonary rehab is shown to be very beneficial, and exercise, which is prescribed 150 minutes of exercise per week. That's what is shown to improve mortality. Long-term macrolides, specifically azithromycin, has been shown to have about 52% reduction in exacerbations. This is something that we start for everyone who has more than 2 or 3 exacerbations in a year. And you'll get this at a dose of 250 milligrams daily or 500 milligrams thrice a week, and will treat you for more than 3 months. Inhaled antibiotics is another big one. If you ever grow Pseudomonas and you grow it for the first time, we'll offer an eradication protocol for you, so we're able to get rid of it at the outset. Doing this is we are able to get rid of it in 40% of the patients, which is still a large percentage of people, knowing that growing Pseudomonas is an independent risk factor for both exacerbations and for mortality. So we hit this bug really hard. And we can put you, if this is not the first time you're growing Pseudomonas, then we offer inhaled antibiotics for you, which some of you know you do 28 days on and 28 days off, and you tailor it based on what you tolerate. Newer medications, bronchiectasis, most of you know of this drug, and a lot of you are probably already on it. Bronchiectasis was shown to reduce exacerbations by 20% when we followed people for 52 weeks in the trials. And one of the dosages showed an improvement in lung function, which is what we hope to see. We're still early in the real world data, but one year out, we're excited to see how that pans out. So, in conclusion, it's important for you to know your baseline symptoms so you can spot changes early on. Familiarize yourself with symptoms of exacerbations and keep track. Start prescribed action plan treatments early, such as antibiotics or airway clearance, as soon as advised. Airway clearance techniques, regular exercise, and compliance with medications help reduce flare ups for you. And the prescribed antibiotics and vaccinations are very important for long term protection. I'll turn it over to Dana, who'll walk you through the details of these.
Thank you, Dr. Vijay Kumar. Dana, we appreciate you presenting next to the group.
Sure. So I'm going to break it down kind of at patient level. What is bronchiectasis? It's a common respiratory condition characterized by permanent dilation of the bronchi or your main airways, leading to impaired mucus clearance, recurrent infections, and ongoing airway inflammation. As a result, you may commonly experience chronic productive cough, sputum production, recurrent pulmonary infections or exacerbations, fatigue, and even breathlessness, which leads us to daily care or symptom management. Symptom management is the cornerstone of improved quality of life, and it's the most effective way for doing this is through airway clearance. That's how we break the cycle. Airway clearance techniques typically help remove retained secretions and reduce infection risk. Common forms of airway clearance can include active cycle breathing, postural drainage, or using specific body positions to help gravity move the mucus from the small airways to the larger airways, autogenic drainage or controlled breathing techniques that loosen and mobilize the mucus, use of positive expiratory pressure devices like aerobica or PET valves, chest vests, which utilizes vibration to help loosen the mucus, or even exercise, which helps to loosen mucus and enable you to expectorate it. Cardio and weightlifting are two things that we all recommend. It's imperative to learn one or more of these techniques and practice them regularly to help mobilize mucus. Hydration is another important element of management of symptoms and quality of life and preventing exacerbations. Hydration helps keep airway clearance up. The mucus is less viscous and easier to expectorate. In many patients, mucoactive therapies like hypertonic saline and mucomist are used to help further facilitate sputum clearance. Bronchodilators also benefit patients who have coexisting airflow obstruction, like asthma or COPD. Bronchodilators work by relaxing the muscles around the airway so the air can move freely in and out and make it easier to perform your airway clearance techniques. Regular exercise and pulmonary rehab can also improve exercise tolerance, reduce your shortness of breath, and enhance your quality of life. Here you see common instructions for respiratory therapies. It's of utmost importance that you follow a clear plan, and knowing the order of therapies is also very important and keeps you able to take care of yourself on day-to-day management. So what is an exacerbation? We've talked a lot about that. To break it down, an exacerbation essentially is a flare-up of your pulmonary symptoms where they become worse than your usual day-to-day variation. As Dr. Vijay Kumar mentioned, signs and symptoms can include increased cough, increase in your sputum burden, changes in the color or purulence of the sputum, worsening shortness of breath, wheezing, fatigue, occasionally a fever, or even hemoptysis. This is when symptom management is key. Management of exacerbations. What do you do? So an exacerbation is typically the worsening of the respiratory symptoms. When an exacerbation occurs, treatment as soon as possible is the goal. Treatment's usually based upon your sputum or those microbiological samples. You may notice that your center requests a new sample when your symptoms increase. This helps guide your treatment course. Airway clearance regimens should be intensified during your exacerbation to help aid with mucus removal. Adequate hydration and supportive care are also vitally important. Antibiotic therapy is also a mainstay of treatment and usually guided by those previous sputum cultures. Oral antibiotics are commonly prescribed for 10 to 14 days. Patients who experience severe symptoms or who have resistant organisms or failed oral treatment may require IV antibiotics and or hospitalizations. Patients presenting with significant shortness of breath, hypoxia, or insufficient oxygen supply, severe hemoptysis or expectorating frank blood, or signs of severe infection require urgent assessment and hospitalization. Long-term prevention of exacerbations. For patients with frequent exacerbations, long-term strategies need to be considered. Dr. Vijay touched on these. That includes regular airway clearance regimens, treatment of the underlying cause, and long-term macrolide therapy such as azithromycin, or the new medication Brinsupri. Individuals with chronic infections from organisms such as Pseudomonas may additionally benefit from inhaled antibiotic therapy. Regular follow-up is imperative for monitoring your symptoms, your lung function, your sputum microbiology, and exacerbation frequency. Prevention. Preventative measures are also essential. Following up with annual vaccines like your flu vaccine, COVID vaccine, pneumococcal vaccines, and RSV vaccines as appropriate can help reduce respiratory infections. Following up on your long-term care plans, so knowing your correct order of therapies and following those maintenance medications, avoiding smoking and environmental allergens, practicing good hand hygiene, and eating a well-balanced diet and remaining active through exercise go a long way to help prevent exacerbations. In conclusion, the takeaway should be effective management of bronchiectasis focuses on airway clearance, infection control, symptom management, and prevention of future exacerbations. Early recognition and treatment of exacerbations can reduce morbidity, preserve your lung function, and improve your quality of life. Recognizing your symptoms, increasing your airway clearance therapies, and keeping in contact with your bronchiectasis and NTM team can reduce complications and maintain your pulmonary health.
Thank you, Dana. My name is Brian Garcia. I'm a pulmonologist here at UAB, and I specialize in the treatment of NTM infections. Dr. Solomon and Dr. Vijay Kumar and Dana Goodwin are going to give us a lot of great education today that is very much data-driven, but I'm going to step out into an area with a little bit less data to support some of the things I'm saying. But nevertheless, they seem to be quite important. And so I'm going to share some of my thoughts on some of the non-pharmacologic components and aspects to treatment, particularly for NTM infections. But I think that you can extrapolate much of what I'm going to discuss to the treatment of bronchiectasis in general. About 10 to 25% is what we think of patients with bronchiectasis also have NTM, but there's data that says maybe less, and there's data that says maybe quite a bit more. And these individuals who have NTM infections like MAC or like Mycobacterium abscessus, they may have pulmonary symptoms, and they often do, but they also oftentimes have symptoms unrelated to the lungs that we refer to as systemic symptoms, or sometimes we call them B symptoms. These symptoms could be things like fevers, chills, night sweats, anorexia or weight loss, just a severe loss of appetite. I often have patients tell me that their body aches, that their joints ache, that they have pains in their chest, but also in their elbows and in their knees, in their muscles. And then this is very common, is that patients tell me that they have a severe fatigue, they have this sense of brain fog, that they have difficulties with sleep, and that they are oftentimes depressed. And whether this is from the infection itself or the aspects of dealing with this disease and the symptoms of it is not entirely clear to me. And then complicating these things further for the individuals with NTM infections, treatment of these infections can be very complicated. Some of these individuals take several antibiotics, several days a week, some of which are oral, sometimes inhaled, and sometimes IV. And although these, although these treatment regimens with antibiotics, and then you add in the types of things that Dana and Dr. Vijay Kumar just discussed, can be very helpful, the side effects of these medicines oftentimes mimic the disease itself and can be very taxing on the individuals who are dealing with these. So one of the components of non-pharmacologic treatment that I really stress on in clinic is exercise. Patients will often tell me things like, when I ask, do you exercise? They say things like, oh yes, I go and I walk my dog. I try to walk a mile every day. And my response is, well, that's good, but I don't think that's enough. And I really, really, really push the importance of weightlifting in particular. All cardiovascular exercise is good, of course, but I really push the importance of weightlifting. And patients ask, well, you don't want me to get short of breath, do you? And I'm not supposed to be short of breath when I exercise. This is what they often say. And I say, actually, I do. I want you to get to what your peak level of exertional tolerance is every day for some period of time. And that's going to be different for everyone. There are people who can jog and they have MAC lung disease. And in fact, I have patients who run marathons. And what causes them shortness of breath is different than another patient who is short of breath when they just do activities of daily living around their home. But what makes us short of breath is when we're at our peak level of exertional tolerance. And we don't want that to continue to decline. If you could go back a little bit, Marty, for me, please. I want everyone to be like this guy here. And if you don't know who he is, that's Tom Brady. I don't like Tom Brady. I'm a Miami Dolphins fan, unfortunately, suffering for 39 years now of my life. But Tom Brady, if you look during his time in the NFL, beginning there in that top left picture, then you go through the years, this man seems to have figured out how to age in reverse. He was 22 in that picture in the top left, and he's in his early 40s in that picture in the bottom right. But he really adjusted the way in which he eats, the foods he eats. He exercises, obviously, but really paid attention to other components, including his nutrition and his sleep. And I don't anticipate making any body go 15, 20 years in reverse, but I do believe that for many people dealing with this infection who don't exercise, when they begin exercising and they look back a year later, they will find themselves in a body that has aged backwards, that they will find themselves able to do things now that they weren't able to do a year ago. And that is a major goal for all of us. I believe that I want everyone to go pick up some light weights and get some cold steel in their hands. And it doesn't have to be much. I tell people, if you've never been to the gym, start with 3 and 5 pound weights in each hand, but do a lot of repetitions and focus on the muscles of the chest and in particular of the back and the upper back. What we see in these individuals is, particularly the ladies with NTM as they age, is a lot of scoliosis. And this affects your respiratory mechanics, your ability for the lungs to normally take in air and blow that air out. And so I really want patients to focus on the upper back and of the of the neck muscles. And our goal when we exercise and we lift weights is really achieving longevity. We don't want to just make it to 82, but we want to be able to pick up our great grandchildren when we're 82 years old. And so we want to be like this guy, Chuck Norris, who I thought for a while was going to live forever. And so if anyone knows who Chuck Norris is, look at that guy right there. It looks like 225 pounds in each side there, pumping some cold steel. If you could keep going there for me. And so why is this? Like, what does exercise do? These infections, and in particular, I believe mycobacterial infections, and having bronchiectasis is very pro-inflammatory. And if we take your blood and we look at proteins related to inflammation, they're going to be much higher than those who don't have chronic infection states. And brensocatib is a step towards achieving medicines that help to lower inflammation, but it's still just a stepping stone. And when we exercise and when we lift weights in particular, our body begins to make the balance to those pro-inflammatory proteins. It starts to make anti-inflammatory proteins. This, I believe, helps with things like fatigue, the brain fog, and those joint aches that people complain about. So I'm going to briefly touch on sleep, nutrition, and mental health. These are very, very broad topics. I'm not going to get into the nitty-gritty, but just to reinforce the significance of these 3 parts of your health. We know in chronic lung disease, sleep disturbances, whatever they are very predictive of patients' outcomes. And so for that reason, if you're having difficulties with sleep, that's not something completely unrelated. That is something that we need you, and we probably should be doing a good job of asking about, but we need you to bring it to the forefront. Let us know, as your physicians and pulmonologists, I have trouble falling asleep. I'm not staying asleep through the night. I fall asleep and wake up, and then I can't fall back asleep. Because these might need to be addressed. And depending on other health issues, your doctor might choose, hey, you need a sleep study, depending perhaps on the severity of your coexisting lung disease, or maybe say, maybe we should try some medicines to help us with sleep. Sleep is restorative, and that's when your body is rebounding from the things you did that day. It is so critical as part of your own healing that you get a good night's sleep. And I really believe, in fact, that weight-bearing exercise helps us get a good night's sleep. So next, again, just briefly, nutrition and diet. This is, again, a vast topic. Patients are quite keen to the significance of this, and we lack a lot of information to really guide us in how should we be coaching you with regards to these. In general, if possible, I love to refer patients with bronchiectasis and NTM infections to dietitians. These individuals oftentimes have been losing weight. They oftentimes find that certain foods that they previously liked that they're no longer interested in, or maybe that just applies to food in general. And then they oftentimes have some sort of chronic GI issues. They often tell me that they had constipation or diarrhea throughout their lives. But then this is made worse by the medicines and particularly the antibiotics that we give. Talking with a dietitian, discussing things like macros, how much protein do I need? How much fiber do I need? What types of foods should I be consuming to help with digestion, which sometimes can be difficult in people with chronic lung disease? I think that patients find this very helpful, and nutritionists and dietitians are more well prepared to discuss these topics and oftentimes have the time needed than is available during the clinic encounters with the pulmonologists. And I wish that it was easier to be able to get these individuals into these people's hands. Along those lines, I did not comment on this but in the notes here, but I want to comment on it verbally, is the importance of a probiotic. I believe that probiotics are critical to our health. Now you can get this in a pill or in a gummy bear like we give our children at home, or you can get this through live cultured yogurt, kombucha, and fermented foods. I, in particular, think I actually eat yogurt every single day, not because I necessarily like it, but I am so convinced of the long-term effects of having a good microbiome, having good bacteria in our bodies. And oftentimes that comes from the food that we eat. There's still a lot to come on this, and better understanding how the microbiome of the gut affects the microbiome of the airway, because the airway does have a microbiome. This is the types of bacteria that make up our airway. There is going to be a lot of opportunities over the next decade or so to better understand this as it pertains to individuals with bronchiectasis and NTM disease. And last, I'll touch on these neurocognitive and mood symptoms that patients describe: the brain fog, the fatigue, that they're not operating on all cylinders like they were. And part of this, I think, comes from the infection itself, that dealing with that chronic inflammatory state causes some cognitive dysfunction. But then there's also this mood aspect, and then the interplay back and forth. Patients often say, why did I get this? Why did I get this now? I'm supposed to be retired. I've never smoked. I'm supposed to be enjoying these years. I did nothing to deserve this infection, so to speak. And we don't often have a great answer for that, but this is very depressing for them. And then the treatment burden is very depressing for many people, that they have to do so much every day, so much burden of time towards taking the medicines, the symptoms related to the medicines, the time related to cleaning the medicines, and last, not knowing other people who deal with this, thinking of themselves as being on an island. I've never heard of this disease. I don't know anyone else that has it who I can talk to and get advice from. And so it's this interplay between the disease itself and then this off downstream components of what the disease has caused. And when this occurs, this can make all of the rest of the disease worse because we don't want to exercise, we don't sleep well, and we are not eating well when these are problems. It is not uncommon, and I call this non-pharmacologic treatment, but it is not uncommon that I prescribe medicines for mood disorders. And if a person's having sleep issues or if a person's having appetite issues, I might choose one type of mood type medication that I think helps tackle multiple of these symptoms that the individual is having. So I think it's very important that you talk and you bring up these symptoms with your pulmonologist and say, Doc, do you think that this might be related? Because I think many of us will say yes. And if we want to make you feel the best you can, we probably need to treat it. And last, when necessary, we need to get individuals in to meet with mental health experts, psychiatrists, to help with regards to the talk therapy and medication management to optimize this aspect of the disease. I appreciate y'all listening today.
Hello, and thank you for joining us. Whether you've been living with bronchiectasis or NTM for years or were recently diagnosed, today's message is simple. You play a critical role in the success of your treatment plan. During the next few minutes, I'll discuss practical ways to partner with your healthcare team to achieve the best possible outcomes. So you are the most important member of your team. Your care team includes pulmonologists, nurse practitioners, nurses, pharmacists, respiratory therapists, and most importantly, you. Many patients think their healthcare team is responsible for their treatment success. While we're here to guide you and support you, the most important member of the team is you. The choices you make every day has a significant impact on your lung health and quality of life. So the daily habits that make a difference, small actions equals big results. Airway clearance as prescribed. That's mostly the main important thing you should do on a daily basis. Take your medications consistently. Stay physically active. Drink plenty of fluids. Follow your treatment schedule. Bronchiectasis and NTM treatment is often a marathon rather than a sprint. Missing treatments occasionally happens, but consistency over time is one of the most powerful tools you have. Small daily habits help and improve overall well-being. So communication does matter. Help us help you. Contact your care team if you experience increased cough, more mucus production or changes in the color of the mucus, increased shortness of breath, fever, blood in your sputum, medication side effects. So one of the biggest challenges we see is patients waiting too long to report the symptoms. If something changes, please let us know early. Intervention often helps us address problems before they become serious exacerbations or hospital admissions. So staying engaged in your care is ways to be an active partner. Complete requested lab work. Submit sputum cultures when requested. Keep follow-up appointments. Bring medications updates to us. Use the UAB patient portal or the pulmonary access line to contact us. Ask any questions. So being engaged in your care helps us make better decisions together. Lab work, sputum cultures, and follow-up visits provide valuable information that helps us monitor your progress and adjust treatment when needed. So one small change can make a big difference. Here's a challenge for the month. Choose one area to focus on. Try to be more consistent with your airway clearance. Drink more water, better hydration, daily walking or exercise, improve medication adherence, earlier communication with your care team. And in closing, I want to say thank you for being part of the UAB Bronchiectasis and NTM community. Remember, treatment success is built through partnership. Together, we can work towards fewer exacerbations, better symptom control, and improved quality of life. We appreciate the trust you place in our team and look forward to continuing your care journey.
Angela, thank you very much. And now I'm going to conclude us off after Angela finishes talking about our care center just to give you an example of how that works. Then I'm going to conclude off with the last section of our presentation.
Okay. So I'm the nurse coordinator of the UAB, NTM, and Bronchiectasis Care Center. Dr. George Solomon, he is the director over the Bronchiectasis Clinic, along with Dr. Vijay Kumar, and Dr. Garcia, Dr. Inestroza, and Dr. Ravel. They are with the NTM Care Center. We have 2 nurse practitioners that are with us in the Bronchiectasis and NTM Clinic, Dana Goodwin and Camila Ramira Cruz.
Great. Thank you very much, Angela. And I also want to say that we're a lot of other folks, including respiratory therapists, specialty pharmacists, dietitians, and social workers join our clinic pretty routinely to help with patient care and to manage some of these things we've been talking about today.
Yes.
I'm going to conclude by talking about the future of bronchiectasis exacerbation and symptom management, just to say that we've learned a lot about the disease state, but there are things we don't know fully yet. There are things that aren't fully treated by current therapies or they're not optimized. And so I'm going to give you guys a few glimpses into therapeutic development that are happening and understandings of the disease state so we can get a better understanding of how this disease is working and where we're going in the future. So the objectives for this section are to review the new therapies for symptom and exacerbation management, understand some research gaps in our therapy development, and discuss the future landscape of development of new therapies. So I'm going to think how to help us think about a case. This is the case I actually presented last year when we presented for World Bronchiectasis Day, but I think it's still apropos. So this is a person who's near 60, a female with prior history of Mycobacterium avium lung disease, like Dr. Garcia was talking about earlier. She's had a 4-year history of chronic productive cough. She's had dyspnea on exertion, that's what that DOE means, fatigue and recurrent infections, resulting in frequent antibiotic courses and 2 recent hospitalization admissions for pneumonia and some hypoxia and respiratory failure. You told her she's got bronchiectasis and began to devise a treatment strategy. And despite treatment with bronchodilators, which were mentioned earlier, hypertonic saline, azithromycin, she continues to experience infrequent infective exacerbations, and because of that is having progressive symptoms. So she's asking you, what can I do? We talked about the vicious vortex or cycle earlier, and this really tells us that there's a lot of different problems in this disease state. Chronic infections, chronic airway inflammation, which has been touched on significantly during this discussion, impaired clearance of mucus, and lung destruction, all of which interplay with each other to drive progression. And what we think happens is that doesn't just drive flare-ups of the disease, but it drives daily symptoms. And that makes many of the issues that our team has been talking about today progress and get worse over time and can result in permanent lung damage, permanent disability, and the risk for death from this condition. And so we really want to interrupt this cycle as best we can. Now, there are treatments to treat bronchiectasis, and those include anti-inflammatory and anti-infective therapies, which we talked about, and mucus clearance therapies, but they're generalized. And at this point, we have very few approved therapies, but however, I'll talk about one for just a few moments. There are also no approved anti-infectives, so we have to borrow the use of these from other conditions, including cystic fibrosis. And these are important and helpful, but the results in exacerbations and symptom management from the development of these types of inhaled antibiotics has been mixed. And so what we're left with is a question about whether or not we can move these forward to treat patients or not, and how they're going to be effective for people. So those are unanswered questions we have in the world. As we discussed earlier, exacerbations are episodes of advanced inflammation, usually precipitated by an infection, where the tipping point of both underlying problems with inflammation and other causes, including inflammation and infection, tip the scales towards worsening symptoms, worsening radiograph, and the propensity for worsening of the disease state overall, and the inability to heal up and clearly and improve long term on the current state of health. And so lots of inflammatory pathways have been implicated in this. A most common of these is the neutrophil-derived proteases. These are enzymes that are involved with mucus clearance and inflammation and clearance of bacteria. But when progressive, due to frequent exacerbations or frequent symptoms, they can cause the disease state to worsen, and many of these aspects of the vicious vortex to progress over time. As was mentioned earlier, this frequent exacerbator phenotype is a disease state that we define as people that have frequent exacerbations. And the reason this is important is because this has become a way we can develop therapies, is to reduce the frequency of these exacerbations by treating aspects of the disease. Now, the reason this is also important for our discussion today is that frequent exacerbators, people that have lots of exacerbations, that's usually because they have more frequent symptoms at baseline. So they tend to have more symptoms which flare up more often in many instances. And this begets more exacerbations over time, as was discussed earlier, and worse outcomes, including risk for death, risk for progression of disease and disability, and risk for worse symptoms over time. So as was described by this excellent set of investigators some years ago, this may be a way we can treat an aspect of disease, the exacerbations and inflammation causing those, to treat other aspects of the disease like chronic symptom management. We were really lucky that within the last year, there's been an approval of the drug called Bronchiectasis after the Aspen study was released with results which included reduction of exacerbations. Now, the reduction of exacerbations was fairly modest in this trial, but was significant, reducing about 20% of exacerbations over the course of a year in patients followed taking this medicine compared to placebo. What was more interesting is that there also appeared to be a reduction of lung function decline in patients taking the higher dose of this medication. That's what the upper graph shows. And there were some improvements in respiratory symptoms, but these symptom scores, which we call patient-reported outcome measures, fail to reach the threshold of what's considered a clinically important difference in symptom reduction. And so while there were significant improvements in symptom scores, the patients did not have reduction of symptoms in a consistent basis to suggest that this was a way that we can use as a way to treat therapy for symptom management solely. So in other words, there's going to be patients, including some of you that are taking Bronchiectasis, that are still having symptoms. And we anticipate that based on the findings from the clinical trials, which have been resulted recently. There are lots of therapies in the pipeline in addition. So this is what's good is there's a lot of things being developed in the future to further move various aspects of the pathogenesis of bronchiectasis forward with therapeutics. One of the common things that we think drives a lot of the symptoms, including the cough, sputum production, breathlessness, and perhaps perpetuates progression and disability, is untreated mucus accumulation and mucus plugging. So this is an area that we're really focused on in our research center, is developing therapies that can help with this impaired mucus and mucus accumulation. Mucus accumulation in bronchiectasis is due to several different causes. I'm not going to review this, but just to say that there are lots of abnormalities with the mucus compared to people that don't have bronchiectasis that make this very difficult to treat. And there's a lot of consequences of the mucus abnormalities. They provide a niche for bacterial colonization and for chronic infections, including biofilms. They perpetuate chronic infection and inflammation, and the mucus plugging directly leads to further airway damage and disease progression. The result is this vicious cycle of infection, inflammation, and progressive lung damage we've been talking about. This picture on the right shows severe mucus plugging in a patient with bronchiectasis. And what we can ask is, what is the major driver of symptoms and disease progression? We think that mucus plugging is one of those major drivers. So we are all out thinking about ways we can develop treatments and other therapies that help with mucus plugging. Now, all the current guidelines, including an upcoming guideline coming from the U.S. sphere and a recently reported guideline from the European Respiratory Society and others which have already been published, consistently recommend airway clearance and exercise. You've heard that from several of our team members today. These are really important for helping to clear out the lungs every day of these mucus plugs. But we know despite all these efforts, there's still going to be mucus plugging and progressive inflammation due to that happening. So we have to have other therapies. One way of targeting this is the use of ion channels to augment their function. The reason this is important is because already in use broadly in people with CF and bronchiectasis is the use of CFTR modulators, which is a common way to activate a channel called the CFTR protein, and that helps to hydrate the mucus and makes it clear easier. There are a number of other ion channels, including the ENaC channel and others, which are being targeted for therapies currently in CF and in people with non-CF bronchiectasis to help better clear mucus and may be more central to the pathology of the abnormal mucus that we can treat. In addition, we can see that many therapies may be developed which can help with the clearance of the mucus itself. This is a therapy we've been involved with developing called Arena 1, and what you can see is compared to treatment with the placebo treatment, the Arena 1 when treating with human cells would have impaired mucus clearance. This drug helps the mucus to clear much better, as you can see from the middle panel, and that's what this graph shows us. This drug helps to inculcate into the mucus and helps to make it thinner and easier to transport out, so the body's natural ability to transport is augmented. We've been studying this in a phase 2 trial, which were recently published, and we found that patients actually got significantly better, which I'll show you in just a moment. The interesting thing about this trial is that it targeted patients that didn't have frequent exacerbations per se, but had a high score for symptoms, including significant mucus and sputum production and phlegm in their chest. And so we use a score called the CAT score that you're probably going to be hearing more about on research in the future, which looks at many of the symptoms very near and dear to you all that have mucus burden with your disease state. And so in this trial, we enrolled about 40 patients and randomized them to either treatment or placebo if they had these elevated symptoms. And so this drug is really targeting symptoms. What you can see is that in the green bars on the left, that patients had reduction of these symptoms as evidenced by improved symptom scores using this CAT score and other scores which are commonly used in bronchiectasis, indicating this drug may help with symptoms as a treatable phenotype for the disease state. Now, what we also know is that mucoinflammation or the mucus inflammation interaction is very important. And there are several drugs which are being studied. We talked about the bronchiectasis drug, which suggested in studies after its approval that in fact mucus-related symptoms may be improved, and there may be improvement in the mucus content or the mucin content in the sputum from these patients. But this was a small study. In addition, drugs like ensifentrine, which have been approved previously for COPD, treat both aspects of mucus clearance and inflammation in an interplay. And so we may be able to treat mucus and inflammation simultaneously in certain instances to improve symptoms as well. Now, on the horizon, there are new and targetable treatments that we think will give rise to treatments to targetable traits which give rise to symptom burden. These include chronic infection, certain bacteria, including NTM treatment, airway inflammation, including neutrophilic, which we've already talked about, and eosinophilic and abnormal mucus. And so we hope that interplay of all these things and recognizing what ways we need to be treating them and which types of patients will help us to improve that. And so there are, as you can see, there are tons of ongoing studies which have either recently concluded or are being advanced in various phases of research to help with these aspects of disease that we know drive a lot of symptom burden. And there are new ways we're developing to understand the disease state itself, including these endotypes or types of biology which result in symptoms and exacerbation propensity that can then be treated and targeted. But there are other areas that need more research. We need to understand the key symptoms. This is going to take a partnership with the new research areas in the patient community to understand what types of patient-reported outcome measures are necessary to make the community feel like their symptom burden is being reduced, and what symptoms are important. We talked about some of these: fatigue, breathlessness. Is it symptoms that are outside of the lung itself that are most important? What's the role of rehabilitation and exercise, and can we make it more accessible? How do we extend the benefits of new therapies to more people that weren't treated in the trials or that may not benefit optimally? And furthermore, how can we treat other aspects of the disease or commonly associated comorbidities or causes of bronchiectasis to best optimize the therapies for patients to minimize symptoms? So I'll conclude by saying that we're advancing a better understanding of the interplay of pathophysiology and clinical outcomes in bronchiectasis to improve symptom burden. We know that neutrophil-derived proteases, such as elastase and chronic infections, drive patients to increase severity of the phenotype in bronchiectasis. And thankfully, we've had a first targeted cause of symptoms in bronchiectasis, which resulted in improved therapies, namely bronchiectasis, and there are many more on the horizon. And further understandings of disease mechanism in partnership with you to understand how this results in symptoms will lead to better understanding of therapeutic options and a host of exploratory therapies. And so again, from the behalf of all of our team, I want to thank you for the opportunity to speak with you today. We look forward to the live Q&A.